All right, good morning, everyone. I'm going to get us started and just go through a few housekeeping items before our presenter starts. Thank you for joining us today for the Interior Boost Collaborative Educational Webinar 1. I'm Valeria Gall. I'm the project lead with the BC Centre for Excellence in HIV/AIDS. And I'm happy to have the opportunity to have you all join us today and have an opportunity to listen to Alison Kite and present on the peer inclusion program in Interior. Just a couple housekeeping items. The session will be recorded for educational purposes and posted on our Boost website. If you have any concerns with that, just send a direct message to Angie at CFE Boost on the chat list there. And if you can, in the meantime, perhaps type in your name and location in the chat so we can get a sense of who's all with us today. So I'd like to begin by acknowledging that the land on which we gather is the traditional, ancestral, unceded, and occupied homelands of the Coast Salish peoples, including the 7 Interior Region First Nations, where we live, learn, collaborate, and work together. This region is also home to 15 chartered Métis communities. It is with humility that we continue to strengthen our relationships with First Nations, Métis, and Inuit people across the interior and province. We also want to acknowledge that others may be joining from different traditional homelands today. This acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous people in the healthcare system. I want to acknowledge our funders who are making the Interior Boost Collaborative possible, and that's Health Canada's Substance Use and Addiction Program, Shared Care, the BC Centre for Excellence in HIV/AIDS, Interior Health, and all of our client partners and family voices. Just a reminder that the Zoom control panel is on the bottom of your screen. If you could remain muted for the session, we invite everyone to turn on the camera so that we can see who's on, but we respect if you want to keep that off. It is 8 o'clock in the morning, so that I understand. If you have any questions as the session goes on this morning, feel free to type them in the chat. We will have time for Q&A at the end of the presentation, but I understand if you think of questions during the morning, feel free to type them in. And there will be a few anonymous polls, and this is for us to get feedback on the session itself. So if you wouldn't mind clicking through there and providing your feedback. All right, so I'd like to introduce our speaker today. Alison Kite is here to present on interior health peer inclusion involving peers in Boost Collaborative OAT clinics. Alison is the practice lead for peer inclusion with the Substance Use Services Team, MHSU Network at Interior Health. She has a Master in Leadership from Royal Roads University and a Bachelor's in Anthropology from the University of Victoria. Alison's work focuses on engaging and including people with lived and living experience of substance use in all levels of healthcare system and service planning and delivery. She's passionate about ending stigma and strengthening organizational culture that values lived experience, expertise alongside learned expertise. I will now hand it over to Alison.
Thanks so much, and thank you very much for having me here to talk about this morning. I'm going to share my screen, and I hope I won't have any technical difficulties, but if I am freezing up or cutting out, if someone doesn't mind unmuting to maybe let me know, that would be great, because I just won't be able to see my chat box too easily. All right. Okay. So as mentioned already, we're here today to talk about interior health peer inclusion and involving peers in the Boost Collaborative OAT clinics. Thank you very much for the land acknowledgement that was already done. I would like to acknowledge that I myself am on the traditional, unceded, and ancestral territories of the Selk'ks Nation and peoples, and I'm grateful to be living here. Also want to acknowledge the Métis and Inuit citizens who reside in this health or in this health region, but in particular in this area where I also reside. I also want to acknowledge the war on drugs, the substantial loss and devastation caused by the war on drugs and its racist and capitalist underpinnings. Our peer inclusion work is rooted in respect, love, and great appreciation for those we have lost in the drug war and those who continue to fight for survival. Today, we'll go over a couple of different pieces, including defining what peer means within interior health. I'll provide an overview of our peer inclusion project. We'll talk about the importance of peer involvement, the peer inclusion engagement toolkit that we have available within interior health. We'll go through the process to involve peer advisory group members, as well as the process to involve peer volunteers. And I'll show you some supports and tools that are available and end with questions. So it's certainly not just me behind the scenes. We've got a wonderful team of people who have really made this peer inclusion work happen. So I myself am in the practice lead role. There is also a very important person, Jamie Pereira, who is the coordinator for peer inclusion and definitely a close partner in this work. We also have a knowledge coordinator who spends some of her time on the peer inclusion work, and that's Erica McLaren. And then we have peer coordinators working in Kelowna, Penticton, Kamloops, and Vernon. You'll see that there isn't a name next to Vernon. Adrian Priest has been doing that job in such a wonderful way, but has transitioned into a new role. Of course, if you happen to be in Vernon and you're looking for someone to consult with on peer inclusion there, Adrian is still very much available to do that. So within interior health, we define a peer as someone who has a role within an interior health substance use service or an advisory group where their lived expertise of substance use, whether that's past or present, is identified and central to their role. And peer work happens is only considered such if it draws on and is directly related to that lived experience and happens in a health promoting and or harm reducing context. And we make this distinction because there are many different types of peer roles happening in the community. Many of them, all of them are incredibly important and have their purpose. This is how we define our peer work within interior health. However, I also want to acknowledge that peer is not always the preferred term by people with lived experience. And we continue to have conversations with people that are in peer roles, as well as our advisory group members within interior health about the use of that term. And in some cases, we have developed roles that have terms such as lived experience educator. And so we definitely put it into the hands of people in those roles to have some determination in what the title of their role is, knowing that it absolutely impacts them being in a role with the title peer. So a little bit about the peer project. It started in late 2019. Really knowing that the engagement of peers or people with lived or living experience of substance use at all levels of service delivery and planning is an important priority for interior health, also for the Ministry of Mental Health and Addictions, and also for the Ministry of Health, and ultimately is vital as we work toward greater inclusivity of peers to create a more equitable, responsive, and effective healthcare system. So our project within the Mental Health and Substance Use Network aims to lead and support initiatives that increase and improve interior health's ability to meaningfully and safely engage peers in the planning and delivery of substance use services across the region. So within the scope of this project, we develop and implement the structures, standards, processes, and tools to do that peer inclusion work. We create pathways for engagement, empower peers to feel confident to share their voices, perspectives, and skills, and foster a stigma-free culture that values lived expertise. Here are 2 quotes from the World Health Organization. People with lived experience are experts and necessary partners to advocate for the respect of their rights, but also for the development of services and opportunities that are most responsive to their actual needs. As experts by experience, peers are able to uniquely connect with and relate to individuals going through a challenging time because of firsthand knowledge and experience. I was really excited to see these quotes come out in 2021 from WHO, because it certainly aligns with the importance of peer involvement that was listed by peers within the Interior Health region in 2019 and was outlined in our peer engagement and inclusion framework, which I'll show you a little later. So some of the things that peers acknowledged were important within Interior Health are to bridge the gap between the health system and people who need it through trust, relationships, and hope, to reduce barriers to service by providing a more welcoming, safe, and culturally responsive healthcare service, to strengthen participant attachment to care and the likelihood of people seeking care when they need it, to exemplify a recovery orientation, not to be confused with abstinence from substances or sobriety, but recovery orientation, recovery being self-defined by the individual, where everyone is supported to reach their full potential, and to create opportunities for employment for people with lived experience and reduce stigma associated with people who use substances. So, of course, employment of peers is always the best option. And when that is possible, that is what we are working towards. And we do have examples of employment of peer support workers within Interior Health. But what we're going to mainly focus on today are our honorarium paid peer involvement positions. So we have 2 sort of categories for that. And the first is the peer advisory group, and the other are peer volunteer roles. And the peer advisory group it's a large collection of people. So we actually have over 100 people who have put their names forward to be part of advisory group engagements. And these are more for one-time, short-term, occasional opportunities, often are project or initiative based, always health focused, but usually providing more of an advising, consulting, collaborating type of role. So often can be engagement sessions when you're wanting to get input from people with lived experience on what you're planning to do, or help to kind of look at, what's working well or not working well within your service. Or, that's a really good opportunity to go through the peer advisory group to talk to a larger group of peers and get some feedback. But you can also choose to have 1 or 2 or a smaller group of peers through this group to walk alongside, say, a short series of engagements or involve them in a short-term amount of work. Whereas the peer volunteer program is more of a set term or an ongoing term. It can still have a start and a finish, but with some flexibility. And it does tend to be more of a program, service, or initiative-based approach, and often is sort of that program support or supportive tasks. Although we do also have examples of peer volunteers who are in advisory roles, but they're attached to a specific project and tend to be embedded within that project team for a longer term. So this is just to give you a little bit of information. In the last fiscal year, we had over 100 members as part of our peer advisory group. They represented 18 different communities and nations in the Interior Health region. They shared their voices and perspectives on a wide range of initiatives. So 6 out of that 100 at each opportunity we put out there and say, who, would like to take part in this, who has relevant experience. People put their names forward for what works for them, when it works for them. And so we had 61 unique individuals actively participate in 35 different engagements and initiatives in the last fiscal year. These were our various peer volunteer roles. So in the last fiscal, we had 42 different peer volunteers in 6 different communities doing these 19 different types of roles. So some things that might be of interest to this group would be the Kelowna supervised consumption site and the Vernon overdose prevention site have a number of peers in roles helping to deliver that service. There's also peers both in Penticton and Kelowna doing overdose prevention work, doing outreach into the community. And then you'll see a variety of other things, including integrated treatment teams where peers are doing more of a traditional peer support role versus those supervised consumption overdose prevention are a little bit more of a peer delivered service. So not requiring providing peer support, which is more of that emotional, social, practical appraisal support, but instead really helping to make those services welcoming and comforting, to reduce stigma, to really support that attachment to service. So this is really going to be the go-to for all things that you require if you're looking to get peers involved in your service. So I'm just going to actually just leave that presentation for just a sec and take you to the toolkit so that you know how to get there. Now, if you're in interior health, you'll be able to access this. If you're outside of interior health, you can just send me an email and I'm happy to share these tools via email. So the Peer Inclusion Engagement Toolkit is under the clinical care resources. So when you go to the Inside Net in clinical care resources, you'll go to mental health and substance use. The clinical toolkit list is right at the bottom. And from there, you'll go to peer engagement and inclusion, and that will take you to this page that has various tools. So our framework is here, and this really outlines, it's a document that outlines what we aspire to do with our peer work, but it also has different categories of peer positions and describes the difference between those categories, with really levels 1, 2, and 3 being a fit for our peer volunteer roles, whereas levels 4 and 5 really require employment. And then there are a number of different supporting documents around paying honorariums. We will be looking at some of these documents about how to engage the peer advisory, around how to involve peers. There is a community of practice with the training schedule here, so lots of supports available. Okay, so that's the Peer Engagement Inclusion Toolkit. Now, specifically for engaging peer advisors, so this is, when you really want to connect with peers, you've got an idea, you want to hear if you think it's going to work for them, you're thinking about maybe how to even involve peers in your OAT clinic, and you want to start by just talking to people with lived experience and getting their thoughts on your approach. You could start with an engagement session. And so you would go to that toolkit that I just showed you, and you would open up the how to engage the peer advisory, which really shows step by step what you need to do. It always starts with confirming your budget. If you do not have a budget, then feel free to send us an email at the ihpeeradvisory@interiorhealth.ca, and we're happy to chat with you about whether it would fit within our regional budget for peer engagement. So we typically can support, particularly for these advisory type engagements, to pay for the honorariums for peers to come and provide their input for whichever, whatever it is that you'd like to talk to them about. There is an engagement request form, and so you fill that out with what you're thinking. You do the best you can. It doesn't have to be perfect. There's a back and forth. So it's my colleague Jamie who might come back to you and say, hey, what are you thinking for this? Can you be a little more clear on that? She uses the information in that engagement request form to come up with a recruitment poster and an email, and she sends it back to you and says, hey, how does this look? Is this the kind of experience you're looking for? Are these the folks that you're hoping to talk to? You approve that. Jamie does the work of sending it out to our peer advisory group email contact list. If there is experience that we're looking for that is outside of what we have, then we work with partners. So we have another big email list that includes lots of allies of peers, so social service agencies and others in a network of people who work closely with and provide supports to people with lived experience. So we might send it out there to say, for example, we want to hear more youth voices. Can you help bring youth forward? And then Jamie would help to do that recruitment. She would coordinate the engagement event. She can facilitate it or co-facilitate it with you, and then take notes during that event, which ultimately creates a bit of a report of the feedback. And then you can take that feedback back to your team and determine what kinds of changes you'd like to make and actions that you'd like to move forward from the results of your engagement. So peer volunteers is a very similar process, but we have a different forms. How to involve peer volunteers also just provides a simple process. These are short 1 to 2 page documents that step-by-step let you know how to do this. Also starts with confirming the budget. So certainly for a peer volunteer role, because it would probably be for a term or on a more ongoing basis, it would require a little bit more money to do this. If your program doesn't have that funding, again, send us an email. We'll chat about what's possible, whether it's something that we've got funding within the regional budget to support, or whether we need to write an SBAR or support you in that to go forward for funding. Now, the most important step is clarifying the role, and we have a peer volunteer registration form, which was designed for first the designated interior health staff to kind of fill in what is this role, what are all the considerations, and then it actually goes over, once we've recruited a candidate, to that person that's stepping into the role to fill out their pieces around what are their needs. And so it really becomes an agreement for the peer volunteer role. We also have all kinds of tools, including a peer role description template and a code of conduct template, a confidentiality agreement template. So all kinds of things in that toolkit that will really help you create something that's very particular to the role that you would like to have. And then Jamie, my colleague, she can help with the recruitment process again. So we would come up with, this is the role. We would put that offering out through our email contact lists. People would then submit their interest. So typically for a peer volunteer role, we ask for a little bit more information. We might be looking for, do they have similar experience? So not just their lived experience, but do they have the skill set and interest and strengths that are required to do the role. And then we can support you in that process of creating a bit of an application, doing some interviews, selecting your candidate. And then it really kind of gets handed over to your local team in your Oak Clinic to do the work of orienting and training that person in their role, and ultimately safely and meaningfully integrating them into your interdisciplinary team. And support and supervision is the responsibility of that Oak Clinic locally, with some additional supports from the network that we'll talk to shortly. This is an example of one of the categories that was within that interior health peer inclusion framework. So I just wanted to pull this one up in particular because It's possible that types of roles that you might be thinking for an honorarium paid peer volunteer in an Oak clinic may land within this level 2. So this is where you'll see some other examples down here. So assisting with health promotion groups, promoting low barrier services, outreach distribution, assisting in overdose prevention services. So this is where a number of our SCS and OPS and our overdose prevention peers where that role fits. So really within this level of role, the program or service happens regardless of whether the peer is there or not. But when the peer is there, the service is strengthened. And the peer wouldn't have a high level of interpersonal responsibility. So they wouldn't have sort of, for example, pre-scheduled appointments, but they would absolutely connect with people who are coming into the service. If you're looking for more of that pre-scheduled appointment and more of that one-to-one support, then that would be a level 2 role. Level 3. So at this level 2, we're looking at about $20 an hour for an honorarium, whereas at a level 3, we're looking at about $25 an hour. And then those advisory roles, when you really want someone to consult with you and in an engagement session, that is a $25 an hour role. So here's some of what we can do from our project to support you. So we can support with recruitment for the peer advisory group members or for peer volunteers. We can co-facilitate engagement sessions, take notes, support to write a report of what happens in the engagement session. We can support with peer volunteer candidate interview coordination and support. We can provide support around honorarium payments, so both helping you to determine what the appropriate amount is. That varies based on the role, as you just saw. And we can also support with payment methods. So we have a whole honorarium standardized policy and procedure, and it includes payment by cash, check, or direct deposit. So there's various options. We can provide some support around consultation for your budget. So looking at options if you don't currently have a budget. We also provide peer training. So we can support peers to go through the provincial peer support worker training curriculum. It's actually self-led online modules, but we do a blended model where we have facilitated sessions after a certain amount of online modules are complete, just really to try to integrate the concepts and learning. We also have a monthly community of practice for all of our interior health peer support workers and peer volunteers, which is ongoing skills, education, and training. And we also do consultation, training, guidance, and support for non-peer supervisors and non-peer colleagues for peer volunteers. So this is something new that our knowledge coordinator is really supporting us around. We actually next week are starting a community of practice for supervisors of peer support workers because there is it's a really important piece of it is thinking about how you're going to integrate someone that has that lived experience into a team that has really the foundation of learned experience. And so that's another piece that we can provide some supports around. These are just a couple of references, and that's it. So I will stop sharing and we can turn it over to questions.
Thanks so much, Allison. That was a very informative presentation. Really appreciate that, even from an outsider looking in. It's great to see that. And I think it's really amazing to see the progress that's been made. When I first connected with Andrew and we launched the Provincial Boost in 2019, he shared with us very early on that there wasn't any type of peer program. So to see the progress is really great.
I have a question. It's Jennifer. Hi, Allison. Thank you for everything. It is so amazing to see how much your program has developed and is guiding us and supporting us in doing this awesome work. So thank you so much. You guys are doing a great job. Two questions. So one, the idea of doing peer advisory, does it have to go out to the current peer advisory group, or is there value in us getting peers that are, or clients that are currently getting support from our OAT clinic, and how do we support that? So that's question one.
Yeah, that's a great question. So it depends, I guess, what you're asking about. So there is maybe a difference between doing client feedback. So if you're like looking to say evaluate your program based on the experience of people that are utilizing that, that is a little bit different than diving into the peer advisory group, which is really where people are using their lived expertise really as experts to help advise growth and development, how to strengthen our services. So I think that for within the scope of our program, we would be open to something that was both. So, when we do engagement work, we definitely, reach out to our larger peer advisory group, but we get really specific. So, a good example might be in Vernon, actually, when there was some work around transitions in the hospital related to the psychiatric unit, and then what that path looked like to move out into supports in the community. We reached out into our peer advisory group, and they were looking for very specifically someone who'd gone through that experience, and we didn't have anyone. So in that case, then we did actually go looking, through our own interior health clinicians and services to see if we could find someone who we knew had transitioned from the psychiatric unit into community MHSU, and we're able to bring them in that way. So I think we're always open to include and to find a way to find voices of people that are actively utilizing a service. But I think we probably wouldn't exclusively do that, because that probably sort of falls more within that evaluation of your service from the client perspective, which would probably be more IH evaluation that could support that.
That's such a great clarification. So I really, I really appreciate that, because I didn't really catch that nuance. So I really appreciate that. So that's a really good point for us to really think about when we're deciding what we're wanting to gather, or whether we're wanting to do client questionnaires to get some feedback about the actual service, and then just general kind of feedback. So I guess, is there templates that have been used by other programs, other OAT programs for peer advisory? And is this something that we would have to generate ourselves to kind of get that feedback?
That's a great question. I don't think we've done, like, I can't remember what that number was, but of the 32, engagements that we did last year, or those topics, I don't think we had one on OAT that was specific to an OAT clinic. So we had peers were involved in the Dr. OAT media campaign. So there were pieces of the OAT work that peers were involved in, but maybe not necessarily in specifically, for example, how that service is functioning, or what could be improved at an OAT clinic. But it's even our that asks you the questions to get you thinking about what it is that you want to know. And then really it's as simple as, right, like, what are those things that you'd like to know? You're going to write down those few questions that you'd like to ask. And then Jamie, who's our coordinator for peer inclusion, will really work with you to try to refine those questions, so that we can actually create something that's really specific to your OAT clinic and your needs.
Thank you so much. So I guess that would go back to the Boost group as well. If there was clinics in Vancouver that have done some of the peer advisory work, and maybe they've also could guide us in some thoughts on how to gather some information. So
yeah, that would be a great question to even throw it onto the listserv, right? Because we've got teams on there from Vancouver, Fraser, the island. And it'd be a great way to generate a discussion and hear from others and what they're doing.
Great. And then Allison, the other question, I guess I don't want to hog all the question time, but the other question I have is just going back to the, I want it all. So how do I, make sure we do this advisory piece, but also move forward in getting the peer volunteer hours and budget? And I guess I'm wondering how Kelowna has set that up. And with our OPS, we have peers doing 2 to 3 hour shifts. We have 7 peers. So how I have a little question about that, and maybe that's not appropriate for here, and we can have that conversation offline. But yeah, I just wanted to put that out. That's another question that I'd like to explore with you.
Yeah, it is a really great question. And I do want to just really acknowledge that in Kelowna, they've been able to sort of do our gold standard, which is to hire a full-time employed peer support worker in their OAT clinic. And I know I can see Sam's name there. So she may want to share a little bit about that. But they had some funding, and I always encourage you to talk to your manager, look, and if you can start with a term.
Sorry, Allison, I don't know if it's just
and then there are also SPARs, so there's an opportunity. Oh, I wonder if I froze. Oh, let's see. Did I freeze there?
We can hear you, but you were a little choppy.
Okay, sorry. Okay, I'll take my camera off. That maybe will help a little bit. But so the direction that I continue to receive is always to look at the local budget to see if there is surplus or slippage.
I'm not sure if you cut out again or if it's just, if that was all you were going to add there, to look at local budgets for surplus and slippage.
Okay, am I back now?
You are, yes.
Okay. Yes, so really, we can absolutely talk, anyone who's interested about, support to write an SBAR, support to look at what a term position would be. On the network, we don't have a budget that supports those employed positions. So what we have is an honorarium budget. It's attached to putting peers into certain programs as peer volunteers. So we can definitely talk. We don't have something that's sort of earmarked for peers in OAT clinics, so we would have to get creative in where we find those funds. But I have been hearing from business support that there is surplus in all local MHSU budgets. And here we are 4 months in. This is a perfect time to be thinking about how you could use some of that surplus.
Great, thank you. Does anybody else have any questions or comments? I don't know if Sam, if you are able to maybe share what's been happening with the Kelowna team, if you're able to. I'm not sure if you're speaking, there's a little bit of a static in the audio. Perhaps you could type it in the chat if that's an option.
I think Kelowna's internet connectivity must be really bad today.
I'll definitely follow up with both Allison and Sam directly. So thank you for that information. Wondering then if we could get a little bit more kind of idea from the Boost, because this is part of the Boost project, is really to look at our peer inclusion and advisory. So kind of what is the Boost kind of, I obviously understand why, and I completely drink the Kool-Aid. I'm just wondering if there's a little more direction from Boost on this piece, and kind of to what extent. I guess, I mean, I'm sure it's very individual for each clinic, but I'm just wondering if there's a little more direction from the collaborative.
Yeah, so I think again, it always starts with, you know, the resources available to do it. I think starting small is something that could be done at any level, and, you know, doing a survey with all your clients, something that, you know, they're in the clinic that they could pick up and fill out, or whether it's a link that they could log in, is always a good starting point. It doesn't, you know, involve a lot of time. They could be doing it while they're waiting in a waiting room, and it could be a survey that your team does every year or every 6 months. I know there was a clinic in Vancouver that did something like that. They did a client survey once a year, and it was in paper form in the waiting room. So something like that is a good way to start. It's not too labor intensive, and, you know, you're really hearing directly from the people you serve. I think there was also a team that had just a comment box in their office all the time. So those are small ways to do it when you don't have resources and funding's limited. But I think, again, yeah, it really just comes down to what is it, someone that you want to be part of your team to support clients? Is it someone that you want to be part of your QI work? I think in an ideal state, you would have a full-time peer as part of your team that has a role with the team and supports clients. And as part of that role, similar to all yourself, they are part of the QI work that you're doing, or different types of projects at the site. So that's sort of the ideal state, I would say. But again, it really varies. I know we heard from in a recent project with the MHSU teams in VCH, is that they do have peers in their programs. However, they're contracted out and their hours are so limited. So pulling them from client time to do QI work isn't really the scope of what they're meant to do. And then that takes time away from clients too. So it's hard to find that balance. And it, again, goes back to resources. I think starting with a client survey from the people you serve is a good starting point, because they'll tell you what they think is needed, right? And then that kind of helps you start to look at, okay, we're hearing from clients that this is an issue. How do we, you can shift your focus to that, right? And then you're really speaking to the feedback you're getting from the people you serve. Any other thoughts or comments or questions from anybody?
There's a question in the chat from Tammy.
Okay.
Can you talk about any specific considerations regarding confidentiality and working with peers? I'm not sure if that's a question for you, Valeria, or for Allison.
Yeah, I think Allison mentioned something about there would probably be some signing of confidentiality paperwork, just like any employee would. So I imagine it would be that same process. I suppose if it's a peer that receives services from the clinic, that might look a little different. I'm not too sure. I don't know if anyone has anything to add to that. I don't know. I guess that would be a little different.
Mm-hmm. And I could just say, I don't know, Tammy, if you're asking about confidentiality between staff, so there's because there are a number of different ways that confidentiality actually comes into play when we're including peers. I don't know if you want to provide just a little bit more information about the question.
I'm not sure. Does this have a mic? Like, can people hear me?
Yeah.
Okay. Yeah, just, thinking about, embedding peers in our program, and yeah, that was more about what I was thinking about that would be interesting for our program, and are there any specific pieces that we would need to consider if we were going to think about doing something like that. yeah, that was mostly where I was coming from. That's as far as my thought process has gotten.
Yeah, well, in general terms, there are a variety of things in place. So it depends, how the peers are included. But if a peer is included as an employee, of course, then they are an employee and they have the same requirements to uphold confidentiality and receive the same training around privacy that any employees have. When they are a peer volunteer, part of their process to become a registered peer volunteer and be oriented into the program is to do a little bit of training related to privacy and confidentiality and to sign a confidentiality agreement. And we do have a template for that that really also kind of spells out what that means. And then additionally, in the code of conduct, that's part of the peer volunteer role description. It gets pretty specific and has examples about what it means to uphold privacy and confidentiality. And then there's also can be conflict of interest, that come up. So, when the person in the peer volunteer program has a relationship with the people that are coming in, for example, to use the OAT clinic, then there is some work to do around that as well to understand how, for the peer volunteer to feel that they know what to do when that comes up, what's within their rights. So when they can ask and say, I'd prefer not to work with this certain individual because I have this relationship with them. So there's a number of rights that are outlined in their role description as well. And I know this is coming a little out of confidentiality, but they also have the right to receive service, their own service, in the way that works for them. And so if that means that they also need to attend that OAT clinic as a client, then there's some work to do to kind of look at how that happens and what that looks like. Or if they need to receive service outside of that clinic because they don't want to have those those dual roles, then there's a little bit of work to do to determine what that looks like. So definitely more considerations. And that's where I think the network where we can help, because we've got, lots of peers in lots of roles and our wonderful local peer coordinators who have worked through many of these challenges and issues in all different communities. And so we'd be happy to kind of walk alongside as we sort these things out as well. Another big consideration, though, too, is around the staff that work at the OAT clinic. So if they have information about the person in the peer role as a patient or client, then there is really some work to do, especially from a team leader, to really clarify, what is okay and not okay in terms of privacy and confidentiality, how to shift that relationship from sort of that provider and receiver of service to one that's more of a colleague relationship. So that takes a little bit of thinking and work as well. And that's another piece that as the network we can support with some guidelines and some education that's available. It's complex work, but the benefits are huge. So it's not simple and straightforward, but truly, can make a huge difference between people continuing to utilize the OAT program to come back, to feel safe and welcomed, to reduce stigma, can make a very, very big impact on health outcomes.
Any other questions or comments from anybody? Again, feel free to use the listserv. So basically send an email to the Boost Collaborative Stop HIV/AIDS email address, and that goes out to the entire listserv community to pose questions or share what you're doing, and certainly, Jen, to seek ideas and hear from teams in other regions. I'm happy to send that out on your behalf if you want to send it to me directly. But it's a good way to start a conversation with others that are not on the call today. All right, well, if there aren't any other questions, I'll just move to wrapping us up. Certainly do reach out if any questions do come up after the session, and we can connect with Allison and get get those answers for you. Thank you again, Allison, so much for joining us today and providing this great presentation that really highlighted all the different pieces, but like you said, will create a lot of value in being able to do, to include peers in the programs. All right, so I'm just going to provide a little bit of a little housekeeping and reminder. So we're here at the first educational webinar. Our next learning event is in September. That'll be over Zoom, and there was a link shared on the listserv. Another one will go out every week or so to just remind everyone. Thanks again to all the teams that submitted your monthly reports. We're just in the process of reviewing them and providing feedback, and you'll receive that shortly. If you were not able to send in your report or had issues logging in or any challenges with that, please reach out and I'm happy to connect with you and provide some support there. I'm also really excited to formally introduce Kelsey to our team. If you haven't already met her, she's our new QI lead and coach that will be supporting all the teams with the action period phase of this work when you go back to your teams after our learning events and look at how to apply the knowledge you've gained from these sessions into practice, creating that structure of regular QI meetings. So please do connect with her. She's here to support you and able to join your meetings and really get things going for you. I'm also happy to have Amanda Perry join us. If you haven't met her already, she's covering Andrew's leave for the next 6 months. She's been a great addition to our team and very knowledgeable and able to support in the same way Andrew has supported us up until now. So yeah, just a few reminders, like I said, start to make some time for your regular meetings at each of your site with your specific boost team or whoever's part of that, and invite Kelsey to it. Our next educational webinar is October 18th from 8 to 9. Our next reports are due August 3rd, which is after the long weekend. So just again, start looking at that. You can go into the reporting platform anytime over the month and start entering things in. You can just save it, don't submit. So you can work on it slowly before the due date. And like I said, next learning session, September 22nd, 9 to 3. And as I mentioned earlier, use the email listserv to ask questions, share information, and really network with others doing this work. And also, we still have space to enroll physicians formally in this work where there's remuneration available. So if your teams have a physician that's attached to your team and able to participate, have them connect with us. Like I said, they will be remunerated for their time, so they're not going to need to give up clinic time to do this, but they can at least be part of this work and support the work ahead. Also, if you haven't, take a moment to review the change package and measurement guide that are up on the website. We will review those at the next learning event, but those are a great starting point after you've developed your aim statement to think about, okay, what's next? How do we start looking at different ideas that we can start testing in our sites? And as I mentioned, set those regular meeting times. I know it's hard over the summer with people going away, and I think the key is to set them and then meet for them, even if it's a small group. I think it just creates that structure and place for you to have that time to start working on this. And then again, connect with Kelsey. If you haven't had a chance to complete your aim statement or need support with that, she's happy to help. I'm happy to join as well. Thanks again to all of our partners and funders. And thank you guys all for joining us today. I know 8 o'clock may be early, but we're happy to have you here. We're happy to have Allison provide the presentation she did. If you have any questions that come up, you can reach us at Boost Collaborative at BC-CfE. And this session has been recorded and it will be posted on the Boost website along with a PDF version of the PowerPoint in the next week or so. There is an evaluation for the session, so please take a couple minutes to complete that when you exit out of the meeting. If there's any other comments or questions, I'll be on here for a few more minutes, so feel free to stay on. If not, have a great day. Enjoy the sunshine. Hopefully there is sunshine where you are today, and have a good rest of your week. Thanks again for joining us.